So I'd like to welcome everybody here. My name is Jonathan Kahn. I am a professor of law and biology here at Northeastern and a member of the Center for Health Policy and Law, which is hosting this community conversation on COVID-19 law and social justice. This is the first conversation in a series we're having this fall that I hope you're able to attend more of after today. Today, in the first of these conversations, we'll be hearing from Wendy, Parmet, and Faith Khalik, who will provide a legal and policy assessment of COVID-19. But before I introduce them, I want to remind you again that this is a series, and that also next week, which will be the next one of these, at the same time, Michael Sinha will be speaking on healthcare worker safety and PPE. So after I introduce the speakers, the basic format for today is they'll talk for about 10 or 15 minutes, after which time we'll open things up for a general question, answer, and conversation. Jennifer Hewer, who's the managing director of the Center for Health Policy and Law, will be moderating that conversation. And that's pretty much sort of how things are going. And I think you got the notice in the chat that it is being recorded. Just a heads up to you all about that. So without further ado, let me just provide sort of some brief introductions, and then I'll turn it over to Wendy and Faith. Wendy Parmet is the Matthews Distinguished University Professor of Law here at the law school and the director of the Center for Health Policy and Law. She also holds a joint appointment with Northeastern School of Public Policy and Urban Affairs. Faith Khalik is our legal fellow at the Center for Health Policy and Law, where among her responsibilities, she is overseeing the Public Health Law Watch, which is a collaborative initiative between the center and the George Consortium, which is a network of academic scholars and practitioners in the field of health law. So I'm really looking forward to hearing from them and joining in the conversation as things develop. So without further ado, let me turn it over to Wendy and Faith.
Thank you so much, John, and many thanks to Jennifer. Faith, if you can get the first slide up, that would be great. I appreciate everybody coming at this hour. I have to say, I acknowledge at the beginning of this, I think that our whole community at Northeastern is hurting a little bit and saddened tonight about the really horrible passing, untimely passing of Chief Justice Gans, who has taught at Northeastern Law School many times. As many of you may know, he's also the husband of our colleague, Professor Ramirez. So it's been a hard day in a hard year. We're going to talk about a hard subject. So I appreciate your coming out, and I look forward to your comments. So I just want to say at the beginning that the United States has done, I don't think this is too controversial, or maybe it is, but you know, COVID-19 would be a very hard crisis for any country. All the countries in the world are struggling to contain this pandemic. But when we compare how the United States has done with other countries, particularly peer wealthy countries, there's really not much question that in many, many different ways that you can count it, we've done very poorly. And the question is why? Why have we done so much more poorly than many of our peer countries? And a lot of answers can be given to that question. But in this particular conversation, and based on work that Faith and I and some others have done over the last few months, we want to talk a little bit about the role of law. What did law do? What did it not do? Because one of the things we have concluded is that the legal response to COVID-19 has been, broadly speaking, a failure. So we want to look at the role of law Faith is going to talk a little bit about a project that we have both been involved in since the spring that really tried to do a comprehensive or almost comprehensive analysis and report of the legal response. She'll describe the report. Then I'm going to talk a little bit about the role of law, sort of law's role in creating our vulnerability to COVID-19. How did law leave us in a vulnerable situation? And then Faith will talk a little bit more about some of the tools, the legal tools, and how law can play a role in helping us to get to a somewhat better place.
The rapid legal assessment was put together by a group including many members of the George Consortium, which John discussed, and produced by Public Health Law Watch, which is an initiative of the George Consortium and the Center for Health Policy and Law here at Northeastern. So this spring, Public Health Law Watch put together a series of nearly 30 COVID law briefings with experts from around the country who came together to discuss where law helped and where law hurt during COVID-19. So then from that project came the idea of putting something down on paper, a kind of critical legal analysis with recommendations rooted as much as possible in empirical evidence and in practitioner experience on the major ways that law has been used, misused, or underused in response to COVID-19. So this was the real goal of the rapid legal assessment, which includes 36 assessments on topics ranging from federalism to Medicaid, to housing, to LGBTQ issues. The focus was really these over 100 specific recommendations for federal, state, and local government. And these recommendations, they address not just the legal doctrine, but they also address implementation issues, including both strategies and resources. Equity was also a major concern of the assessment, and most of the authors made recommendations so that persistent health and racial disparities and inequities were not further exacerbated in the COVID-19 response and beyond that response.
The US's poor response to COVID really cannot be laid solely to the failings of our current leadership, although fault can be laid there. We need to recognize the many ways in which our laws pre-2020 helped to create vulnerabilities to the population at large and heightened vulnerabilities, increased inequities among some populations. In public health, we talk about the social determinants of health. These are the conditions in which people are born, live, learn, work, play, and age that affect the health of individuals and populations. We are used to thinking about social determinants as impacting non-communicable diseases such as diabetes or obesity or cancer. But as we're seeing with COVID, and we have seen with other epidemics of infectious disease, such as tuberculosis or HIV or hepatitis, the social determinants of health help to determine the incidence and distribution and impact of many infectious diseases. And we see this with COVID-19, which has had a dramatically disparate impact and has hit communities of color and immigrants and low-wage workers far more severely than it has hit other populations. Importantly for this project is the point that law helps to determine the nature and distribution of social determinants of health, and hence the nature and distribution of disease. Law helps to make us vulnerable to disease, and it helps to decide which people are more vulnerable than other people. If we go through, Faith, slide. If we go through our laws and we go through, for example, the 36 chapters in the assessment, we can see case after case, story after story about how laws left us vulnerable. Let me just give you a couple quick examples. Think about federalism, a core constitutional legal part of our Constitution and a core constitutional law doctrine. Well, in NFIB versus Sebelius back in 2012, based on federalism, the Supreme Court ruled that the Medicaid expansion in the Affordable Care Act was unconstitutional to the extent that it was compulsory upon the states. And the court, in effect, took the expansion and turned it from mandatory to voluntary for the states. As a federalism doctrine, what does that have to do with COVID? It means that many populations in many states have much higher rates of people without health insurance and much more economically fragile healthcare systems than they otherwise would. Or think about many of the doctrines that have really limited our civil rights laws and made it very hard for plaintiffs to prevail. I could also talk about the voting rights laws, and we could go through and see how these laws have disempowered communities of color and also at the same time really condoned structural racism to continue by, for example, not considering the disparate impact of laws or disparate impact of state decisions. Again, these legal doctrines, which we talk about in all different areas of the law, help to create the vulnerability. I'm going to talk in particular for my next 3 minutes or whatever I have left about immigration law. I also put up qualified immunity because we talk about how policing and incarceration has led to increased numbers of cases of COVID. But I want to focus a little bit on immigration because that was my chapter in the assessment. And note that many of our pre-2020 immigration laws or immigration-related laws regulating the rights and privileges of non-citizens, again, helped to create vulnerability. So the 1996 Welfare Reform Act, otherwise known as PERORA, basically banned, disqualified many non-citizens from accessing a wide range of federal benefits and also allowed states to take away even more benefits, Medicaid, food stamps, etc. This led to increases in uninsurance, more food instability, etc. among large populations. Just last February, just as the pandemic was really taking hold in this country, the United States Supreme Court allowed the Trump administration to go forward with the so-called public charge rule, which creates adverse immigration consequences for accessing public benefits. If there was ever bad timing, I don't know what it was. What's a better example of bad timing? In March, the Department of Homeland Security actually issued a guidance and said, well, we won't consider COVID-related health care under the public charge rule. But too little, too late. Advocates are saying, and immigration advocates and healthcare advocates around the country are saying that immigrant populations, non-citizens, are so afraid, terrified of accessing Medicaid or other public benefits that they're staying away from hospitals, clinics, not getting tested. And in part, it's because of this that we see, as you see on the slides, that communities with large numbers of immigrants like Chelsea are really the communities that are suffering the most from this pandemic. I should also talk about employment vulnerability. Immigrants, non-citizens, especially unauthorized citizens, but also citizens with visas, are exceptionally vulnerable to employment. Really, they're not in a position to say, I'm not going to work now, it's not safe, right? If they're working in a workforce that's considered an essential workforce. So again, we see high rates of COVID in immigrant communities. And before I turn it back to Faith, let me just talk about deportations and detentions. So detention centers for immigrants, and many immigrants are in detention centers, but many are in being held in prisons around the country, integrated with the general prison population. These have become, in the words of one federal court, a petri dish for infection. And when you can't socially distance, you can't be safe if you're in this environment. And by incarcerating so many immigrants, we are again exacerbating the pandemic. Deportations have continued throughout the pandemic. And I just end by saying, I think one of the more shocking things is that the United States has been deporting people who are positive for COVID. And in a sense, we are exporting our pandemic and have exported the pandemic to other countries, including low and middle income countries that have fewer resources with which to address it. So these are just a few examples of ways in which laws have exacerbated the problem and made things worse and increased the disparities among populations. Let me turn it to Faith to end with a little bit of more positive note.
Well, unfortunately, I won't really start on a positive note. Looking at places where law was used as a solution or where it could have been used as a solution, but it wasn't, either because it wasn't utilized or because it was underutilized. I think one of the most interesting areas is the Defense Production Act. So under federal emergency law and the Defense Production Act, the federal government has the authority to prepare and manage shortages during medical emergencies that threaten national security. And the act provides a flexible set of powers that enables the executive branch to stimulate production, strengthen supply chains, and resolve market failures. So the government has known for a long time that there have been issues with DPA implementation. So since back in 2008, there was a Government Accountability Office report finding that the DPA implementation process was unclear. In 2009, during H1N1, the stockpile was really used up and then neglected, so that by March 2020, there were only 12 million masks in the stockpile. In 2017, the CDC preparedness staff found issues with preparing for surges in basic medical supply demand during a pandemic. And then in August of 2019, the government conducted an exercise simulating a novel respiratory virus, which revealed that there were sizable PPE shortages. So what happened during this process, during the pandemic? So as the Wall Street Journal reported, HHS officials actually prevented the FDA commissioner in January from reaching out to industry to discuss increasing PPE production because they thought this kind of call would alarm the industry and it would make the administration look unprepared. So then finally at that point, HHS began instructing their staff to draw up plans to invoke the DPA. But federal agencies really only began seriously responding to shortages in March when they placed bulk orders for N95s and ventilators. So what could have happened if the DPA had been used effectively? So back in December or January, the administration could have then rapidly assessed the amount of PPE, ventilators, and other supplies, could have, using DPA, could have convened a partnership of private and governmental sectors to organize a federal response to shortages and invoked federal authority to oversee the allocation. And then when inadequate supplies were really apparent, the federal government could have much earlier issued large long-term purchase commitments to incentivize companies to increase their production capacity. So yes, there were over 100 recommendations in the report. So it doesn't make sense for me to go over all of them, obviously, but I'll just talk about one of the themes that arose during the report, and that was the need to empower state and local governments to enact control efforts. So there are two ways that authors talked about, and one was providing funding to state and local governments, and the other is just getting out of the way of the government, of state and local governments. So as of June 1st, 18 states had blocked local action by preempting county, municipal, or tribal governments. So for example, the Mississippi state stay-at-home order blocked local authorities from enforcing more restrictive orders. So cities that already had orders in place had to cancel their city level mitigation efforts. But 17 states have expressly allowed local governments to impose more restrictive requirements going beyond the state measures. And then some states have gone back and forth. So for example, the Arizona governor partially reversed his preemption mandate. So he allowed local governments, local officials to set face mask requirements, but maintain preemption for other business restrictions. So the report authors argue that states can and should allow local governments to respond to their community needs and expressly allow local governments to impose more restrictive measures. And all right. I don't think I really have time to go through any of the state and local efforts, so I will turn it over to you all for questions. Thank you.
Thank you, Faith. I just want to end with one point, which is that one of the things that became clear to us is the importance of remembering that laws alone don't do the magic trick, right? And that in many instances, for example, the Defense Production Act that Faith talked about, we actually have the laws, but we don't have, right? We didn't have the leadership, or the programs weren't funded, or in many instances, the public health authorities were severely resource stretched. And so we need to remember that law can play an important role, and we think has played a significantly negative role, but law alone is not the solution. We need leadership, we need resources, we need people doing the right thing. Unfortunately, we've come up short in many of these areas. Would love to have your questions, comments. There's a lot more in the report. We just barely touched the surface.